going to do this with some of our residents in the room. I think we have about 8 or 9 residents sitting in the room today who are going to talk us through 3 mini ICU cases that all share a common theme, which will become evident pretty closely. If Corey can stop clapping and smacking his lips next to me, hopefully the audio quality will remain good. All right, so for our residents in the room, which case do you guys want to start with today? Number 1, 2, or 3? 2. Great. So whoever said 2, what is number 2? Does anyone recognize that shape? All right. So there's a cacophony of sounds in here. So that is the Penrose triangle. That is a paradox. So in real life, you cannot create the Penrose triangle because it doesn't like obey the laws of physics. And we will talk about why that makes sense here in just a second. So case 2. We've got a 63-year-old man. Got a 63-year-old man with metastatic prostate cancer, complicated by spinal mets, presenting with chest pain and shortness of breath. He developed sudden onset sharp chest pain and then pleuritic chest pain on the day of presentation. Afebrile, heart rate's 113, blood pressure is 99/67, and he is satting well on room air. He's got an elevated JVP on exam, 2 to 3 centimeters above the clavicle, and 1+ lower extremity edema. What do you guys want to do next for this gentleman?
Blood pressure, his baseline.
Great question, Evan. That blood pressure is not his baseline. So why did you ask that?
I mean, if he's like sitting like 100 systolic all the time, then I'd be less concerned. But if it's not, then it's like dropping.
Great. Yeah. So his normal is 160/90 or around there. So he is well below his baseline. And Evan brought up that he is concerned about whether this gentleman is in sort of shock or a relative shock state compared to his normal perfusion. Cool. So you guys are standing in the room with this person. What test or exam maneuver do you want to do next? Pulses. Great. I do not want to talk about how to do the exam pulses today. I told Eric this morning. My ears are not good enough to hear pulses in an exam room unless there's perfect conditions. So we'll talk about how to measure that in kind of a more objective, chaotic way in a second. But I'll tell you that his pulsus is 20. So that is elevated. Normal is less than 10. Cool. So he's got an elevated pulsus. He has this clinical exam. What do you guys want to do next? POCUS. Great. So you have asked to do POCUS. So let's pull up his images here. So Evan, you asked for the POCUS. So what view are we looking at right now? Great. So parasternal long. And what do you notice on this ultrasound? Awesome. So for those that couldn't hear, Evan said that he sees RV collapse. So the RV is right there. And then he's looking at sort of this whole area all around it right here. He says that is a pericardial effusion, which is absolutely correct. For the room, is this our best view when we are looking at pericardial effusions? No, so great. So this is not our best view when we are looking at pericardial effusions. So what is an even better view if we were going to assess this pericardial effusion in real time? Great. So Elizabeth says she would rather see a subxiphoid. So we'll pull up his subxiphoid here. So here's his subxiphoid. And what do you guys notice on this one? Nice. So Elizabeth says that the RV free wall is bowing in. So she's looking at this area right here. It's bowing in. There's also right atrial collapse. This is the right atrium, and you can see that wall is collapsing as well. And then the reason the subxiphoid is such a nice view for looking at pericardial effusions is you can see whether an effusion is circumferential, just on one side, et cetera. And so if you notice right here, you've got your pericardial effusion, you have pericardial effusion down here. Essentially, you've got a circumferential pericardial effusion. So your subxiphoid, easy to obtain, and our best view for pericardial effusions. So this pericardial effusion ended up being about 6 centimeters in size, all the way around the person's heart with a positive pulsus. So what is the diagnosis that we are working with right now? Awesome. So this person has tamponade. Great. So our first case is a pretty basic case of cardiac tamponade. And I told you guys that, one of the reasons that I don't like checking a pulsus is because my ears aren't great. I can't hear it unless everyone in the room is silent. It's borderline impossible to get a good read on what's going on. And so is there any other way that we can check tamponade, right? Because you're going to send this person to the ICU because they're in shock. Is there any other way that we can check whether a person has pulsus if we don't have a cuff, good ears, or a quiet room? An A line. I love it. So what do we look for on the A line? Awesome. So ask and you shall receive. So here is this gentleman's A-line tracing. So for anyone who feels comfortable, what do you guys notice on the A-line tracing?
Drops about 20 points.
Yeah, great. So Connor. Perfect. So it's a little tough on this one to see when the person inspires. It's a sort of proprietary setting on each one to see the peaks and the valleys of inspiration and expiration. But Connor points out that during these periods here, this period here, this period here, and this period here, the person is dropping their systolic blood pressure. So when they inspire, their systolic blood pressure drops. And this is a pretty classic A-line tracing for someone who is demonstrating pulsus. So I would try to commit this like A-line tracing to memory, because if you can't hear pulses at the bedside, which I have said I have never done in my life, you can always put an A-line in and be very sure and get a very objective measurement of what their pulse pressure variation is.
Chris brought up using Doppler.
Nice. Yeah, so Chris, another great point. So you can also do a Doppler as well and sort of wait to hear that respirophasic change if you're comfortable with that maneuver. So I would say Doppler or A-line will give you a more objective measure unless you have superhuman ears or a superhuman physical exam ability. Okay, so we talked about how this guy is dropping his pressure during inspiration. Does anyone in the room feel comfortable explaining why this is happening? Like, what is the physiologic mechanism of pulsus? Right, so Cassandra, you said that when you inspire, you increase your intrathoracic pressure. Okay. Is that flipped, right? Yeah, great. So you're increasing your venous return because you're dropping your intrathoracic pressure, right? So you create essentially a suction effect. So you take a breath in, your venous return increases, and you get more blood coming into the right side of the heart. So here's a diagram of the heart. This is not a problem, right, if we don't have tamponade, right? Imagine if we have a pericardial effusion like this, and we'll say this is all pus or some sort of junk, which is not going to let our heart move. When you take that breath in and you increase your venous return, this RV free wall can't go out, correct? That RV free wall is sort of stuck there because there's a back pressure pushing on it over here. And so the only place then for your heart to move is for your septum to push this way into the LV. So every time you inhale or inspire, your septum pushes into your LV. And right when you push something into the LV, you decrease that space and you ultimately decrease your cardiac output. And so every time you take a breath in, the septum shifts into the LV, or like Elizabeth said, that RV free wall kind of bows in. You drop your cardiac output, and if you drop your cardiac output, you will drop your systolic blood pressure as well. So that is sort of the underlying mechanism of how pulsus comes about, especially on an A-line. All right, so guys, cardiac tamponade has pulsus on an A-line end exam. I'll say that Logan McCracken did a wonderful exam and actually documented this without an A-line, so he's a better doctor than I am. So what do you guys want to do next? Give him fluids, great. So he gets fluids, you're gonna tank him up, perfect. Great, so I like it. So you call cardiology. Cardiology says we're gonna come do a pericardiocentesis. I've actually never seen a pericardiocentesis, but it's just a needle insertion into the pericardial space. So a needle goes in, a tube is connected, and this gentleman drained 1 liter of serosanguinous output. So if you recall back to his initial HPI, he had metastatic prostate cancer, so this was presumed to be a metastatic pericardial effusion. Once he had a liter drained, his hemodynamics improved, and he was ultimately discharged a few days later with cardiology follow-up. So cardiac tamponade treated with a pericardiocentesis, teaching points being how pulsus happens and then what to look for on that A-line. Any questions about this initial case right here?
They always say like you shouldn't stick a needle if you're in concern for dissection, but I feel like the practice
Yeah, good question. So Melanie said she's heard that you're not supposed to put a needle in if there is concern for dissection. I will say that that is well beyond my pay grade. I would say if you think the person is actively bleeding into the pericardial space and it's going to reaccumulate or you're going to change their hemodynamics even more, defer to cardiology or CT surgery.
They might look like before they're doing it, they might look at the face of the or whatever.
Yeah. And I think that's one of those key teaching points, right? This is never something that a resident should be doing by themselves. Probably not a fellow should be doing by themselves either. So make sure you have all the resources available in the room before something happens. All right, so we've got this case. I'll say the other two cases are semi-related. What do you guys think the theme of this conference is? You got a guess for RV? Any other guesses? Cardiology. It's not cardiology. I will never do a just cardiology conference.
Right.
All right, great. We got some guesses for right heart failure. We have guesses for cardiology, TBD. All right, so case 2 is in the books. Which one do you guys want to do next? Awesome. So case 1. So this is an overstuffed suitcase. Any guesses about what we're about to talk about? Great. Something overstuffed. Perfect. All right, so you've got a 58-year-old man with alcoholic and HCV cirrhosis who came in with hematemesis and PEA arrest. Massive transfusion protocol initiated in the ED. He got 6 units of blood, 6 of FFP, and 2 units of platelets. For those people that were not here last week, we talked about massive transfusion protocol and how it's a 1-to-1-to-1 ratio. He gets admitted to the MICU. In the MICU, Tiffany Gardner admits him. He continues to bleed. He gets MTP reinitiated, and overnight he received 50 units of blood, 50 units of FFP, and 10 units of platelets. So while this is going on, this gentleman is unwell. So right, he's getting an EGD. On EGD, they see that he has esophageal varices, which are actively bleeding. They cannot intervene, and so he's referred to IR for an emergent TIPS. So that is all taking place in the background while this gentleman is getting a sort of massively transfused. So the thing we're going to talk about is you guys are called by the RN who says that this gentleman's peak pressure is 50. It was approximately 25 when he arrived. So we'll defer this to one of the interns because you guys are the ones who are going to be cross-covering in our ICUs. What do you make when what do you think when a nurse calls you and says the peak pressure is 50? Awesome. So Evan asked the great question, which is, can I figure out what that plateau pressure is? And Evan, why did you ask what's his plateau?
If the plateau elevated, you have the decision point of this plateau elevation pressure, pressure.
Nice. So Evan says that plateau pressure is helpful because it helps you distinguish whether the peak is part of another process or it's sort of an isolated elevated peak. So what I want you guys to do is in your small groups in the room, and if you're watching, take 30 seconds, and I want you guys to think of as many causes as you can think of for an elevated peak pressure on the ventilator.
So I was trying to remember.
room. Pretty good discussion in the room, so we're going to come back here. So let's start with our furthest table over there. So what is this point? We'll say, I'll use my pointer here. What is this point up here? Great. So this point right here, all the way at the very top, that is your peak. Great. What is this point right here? Perfect. So that's your plateau. And then if you have those two numbers and you know the person's tidal volume, you can then go ahead and calculate their overall respiratory compliance. And so compliance, or C, is equal to your tidal volume over your plateau minus your PEEP. So that's going to be set. So this number down here is going to be your PEEP. So on this first diagram up here, are we looking at a problem of sort of, respiratory issue? Are we looking at a peak issue, a plateau issue, or a both issue? Awesome. So this one up here, we are looking at a plateau issue. And so plateau is sort of synonymous with compliance. So up here, we're looking at a compliance issue. Great. And how about on this lower one down here? Are we looking at a plateau issue, a peak issue, or both? Perfect. So down here, we are looking purely at a peak issue. And so the peak issue is basically airway resistance. There's a bunch of different things that go into it. But if your peak pressures are just elevated, what is that differential? Feel free to call stuff out.
Mucus plug.
Great, so mucus plug, you bit the tube. Say it louder, Jake. Yeah, bronchospasm, awesome. So those are going to be the big three. So anything that is preventing air from getting in through the endotracheal tube into your lungs. So no reflection on the alveoli, just purely an airway resistance issue or something blocking the tube. So then more interesting, what is the compliance differential? Like what is our differential when we see that plateau pressure elevated as well? Great, so ARDS. Awesome, pulmonary edema. ACS, or abdominal compartment syndrome, perfect. Pneumothorax, awesome. Yeah, if it was bad enough, yeah. Yeah, great. So, perfect. So any alveolar filling, and then the other one is pleural effusion as well. So basically, airway issues and things that are taking up space in the chest are making it harder for the lungs to expand, are going to mess with your compliance, right? Because it's going to take you, basically essentially a larger pressure to distend the lungs the same amount. So this gentleman just got roughly 100 units of blood products or so. What do you think is going on with him? Great. So we got taco and trolleys on our differential.
Or it's just all extravascular.
And what process that we just listed up there, Carl, are you describing? Yeah, awesome. So Carl said that he thinks this might be abdominal compartment syndrome based on the fact that he got so many blood products. Awesome. So this gentleman actually has abdominal compartment syndrome, and his plateau pressure, right? We said his peak was in the 50s, his plateau pressure was in the 40s. And so he has abdominal compartment syndrome from blood product transfusion. So essentially an unavoidable problem based on what he came in with. So let's talk about abdominal compartment syndrome. Who here has treated someone with ACS? Kelly has. So the key is calling TACs. Perfect. So why do we call TACs here, right? The definitive treatment is surgical decompression, but there are other things that we can do before then. One of which is basically get fluid off, so remove fluid. And so if the person is not on that spectrum of critical illness, if they're not like acutely dying, you could trial them on CRRT or a diuretic to see if you can get some of that fluid off. But realistically, this is going to be that end goal, is surgical decompression. So this person gets a bedside XLAP, their bowels basically explode from their abdomen, but their hemodynamics get better. So why does abdominal compartment syndrome do what it does? Like, why is it so bad? So if this is your lungs up here, right? If this diaphragm goes higher and the bowels get more edematous, this encroaches on your lungs, right? Affects your compliance and you can't expand. The other problem is that abdominal perfusion pressure, so APP, is basically equal to your MAP minus your intra-abdominal pressure, your IAP. And so if our map, right, if we want to keep this greater than 65, any increase in this number will drop that. And so basically any increase in your abdominal perfusion pressure will decrease the perfusion to your abdominal organs, which will make them more prone to ischemia, necrosis, all that horrible stuff. So when you're talking about intra-abdominal pressures, normal is basically less than 7, and you get intra-abdominal hypertension or IAH greater than 12. And generally speaking, you're not going to convince a surgeon to do much for that person unless it's greater than 20. So once you hit that magical number of 20, that's when you've really dropped that abdominal perfusion pressure and you're really at risk for some horrible, horrible things. So how do we, for some of the interns in the room, how do we measure this? Like if the nurse calls you, you're concerned enough, what do you have to ask the nurse to do? Cool, so you need to get a bladder pressure. And why do we need to get a bladder pressure? Great, so Noah says that's how you measure it, which is correct. It's a good answer. It's a cop-out, but it's a good answer. Say it a little louder, Megan.
I thought there was something about the catheter that actually measured this that way. It's a way to get into the app, or like into the app without being inside the right?
Great. Yeah, so it's like a super low-tech way of measuring something, but as Melanie and Megan said, there's no other way to get to the bladder, right, that's less invasive than sticking a needle into the abdomen. So you can basically just insert a Foley. So if you insert a Foley all the way up into the bladder and you decompress the bladder, then you essentially have a pressure which you can, kind of say is the pressure for the entire intra-abdominal compartment. So you put in a Foley, so that's gonna be step 1. What is step 2? Yeah, you have to be paralyzed. So why do you have to be paralyzed? Great. So Rachel says that you need to be paralyzed. Otherwise, there's squeezing or there's muscle contraction, which is exactly correct. So all of us, right, if you cough, if you move, all of your abdominal muscles will contract, whether you want to or not. And so if you're not paralyzed, you're going to get a contribution from all of the rectus abdominal muscles. So you basically paralyze to take the muscles out of play. And then after that, it's basically the nurses zeroing the catheter, making sure it's level, and taking a bladder pressure. So notably, right, you don't have to be continuously paralyzed to measure this. You can do it with a paralytic bolus, but if you're going to do that, you need to make sure they're sedated before you paralyze them at all. So Foley, paralyze, get the number, and then talk to your attending or call TACS to see if they want to do anything.
To that point, do we need to order a special catheter? Like, is it different tube?
Cool. So great question. So Noah asked, do I need to get a special catheter to do this? And the answer is no. So this is a normal Foley catheter. They essentially clamp the catheter and they can take a pressure off of it with a special transducer. Yeah, so this is a normal catheter in the MICU. You can measure this. Just make sure the person is paralyzed. Awesome. Any questions about abdominal compartment syndrome? Yeah, good question. So Megan asked, how do they keep the bowels sterile once they open it up? And so if this gentleman is open, right, and this is his kind of incision here, they put something called like an Abthera or wound vac device over it. And so they basically layer a wound vac device just like this, and it's sealed. And so it looks almost like saran wrap, but it's sealed on top of the abdomen. And so what they do is they put it on, and then you have to go back to the OR in a couple days for either closure or washout. And so basically once you put on the wound vac device, the person's not out of the woods yet. They still have a couple operations at least in front of them. The other really interesting point is just because you decompress the abdomen does not mean that you're out of the woods from abdominal compartment syndrome. So right, if this incision is not wide enough or there's still edematous, you can still get ACS with the wound vac device on. So just because surgery has done something doesn't mean that the person is better. It just means that there's a kind of a release valve. He did, yeah. So he got a TIPS. This guy got a TIPS with an open abdomen, and between the TIPS and the decompression, his hemodynamics got better, but he unfortunately did not survive the multi-organ failure that resulted.
Were they put him in a sedative then before they still believe it was very procedures in that?
Yeah, good question. Corey asked, did they put a Minnesota tube in? They did not put a Minnesota tube in because they couldn't correctly place it. Basically, there was concerns that it wasn't actually in the stomach the entire time. And so he did not get a Minnesota tube. They just transfused him through it until he could get to IR. All right, abdominal compartment syndrome. It's a horrible thing, but be on the lookout, right? If people have pancreatitis, massive transfusion protocol, or any other volume. So if you see your patient's 25 liters up, they're hypotensive, consider this on your differential. All right, last case of the day. Yeah, good question. Evan asked, can you prone an abdominal compartment syndrome person? I think it's a relative contraindication. You can ask TACs. TACs will sometimes say it's okay, and sometimes they say it's not okay. The dressing will cover their abdomen, and so you're not worried about like contamination. I think it's just a question of whether TACs is comfortable with them rolled. I'll say that I have never seen it, but I've heard TACs say it's okay to do. Yeah. All right, so we've got ACS. We've talked about cardiac tamponade. What is the theme of this conference? Stuff in a small space, great. Or if we were talking about a form of shock, great. So this the theme of this conference is obstructive shock. So a form of shock that we probably consider less than the others because we just see it less, but we're going through the 3 most common causes. So what do we think this last case is going to be about? Awesome. So we're going to talk PE. So you've got a 63-year-old man with HIV on heart. He's got bipolar disorder. He has a recent PE, not on anticoagulation for about a month, found down, unresponsive, and hypotensive. In the ED, he got increasing doses of vasopressors. Labs are notable for an elevated trope, lactate, and BNP, and a bedside ultrasound is obtained. So the RAC residents have been doing a lot of good ultrasound stuff with Brandon. So I'm going to pull up an ultrasound image for you guys. This is his... they could not compress his IJ, so they went down to his femoral veins and his femoral artery. And this is an ultrasound from that area. It's not a video because my computer wasn't working this morning. But what are we looking at here in this ultrasound of the femoral vessels?
It's like artery on the left, vein on the right, and if they're compressing, it should be gone, and then there's stuff inside the vein.
Great. So Connor says that the artery's on the left, the femoral vein is on the right here. They are compressing right now. This is obviously not compressing. And then this thing in the middle here is some sort of echogenic thing. And Connor expertly said that this is a clot. So this gentleman has clots in both of his IJs, both of his femoral veins, and is currently in shock. So they also were kind enough to get an ultrasound, which I couldn't pull, but I am cheating and I'm going to use one from another patient. So here's an ultrasound from another patient, which is exactly what they saw. And I will play this. It's a positive gasping sign in the room. I'm going to give them about 15 more seconds before they tell us what we're looking at. All right, for one of our, what is it, intern level question? I like it. So interns, normal or abnormal? Awesome, so abnormal. So what chambers are we looking at? More complicated question. Yeah, so these are the atria up here. It's harder to see, but like take my word for it that these are the atria. And so now for anyone in the room, what is the abnormality on this? Great, so you've got a right atrial clot. So this whole like Goomba there that's kind of like swirling around is concerning. And so referred to as a clot in transit. So kind of just a term for seeing a clot, seeing it inexplicably swirling around the atria. All of us are concerned, and this is a clot in transit. So what is the diagnosis for this gentleman? Great, so he has a massive PE. So going back to Evan's initial point at the very start of this talk, Evan, why does this guy have a massive PE? Cool, so if you're in shock, you have a massive PE, perfect. And then Elizabeth, is there any other criteria? Or is that it? That was a very, I put her on the spot. That was a very specific question. Great, so right heart strain doesn't necessarily get you there, but what is the other criteria that gets you massive PE? What did the first patient have, vital sign-wise? Pulses, okay. Yeah, so hypotension. So if you're not in shock, but you're hypotensive and your systolic blood pressure has decreased by, that's going to be a very confusing way to do it, less than by greater than 40 points, extremely confusing. But if your systolic is dropped, that's dropped. I've had a stroke. If your systolic is dropped by greater than 40 points from your baseline, you meet criteria for a massive PE. So hemodynamically unstable or basically severe relative hypotension meets criteria. So how do you guys want to treat this gentleman? TPA? Cool. And how much do you want to give dose-wise? We're not at the U for this. We're at Denver Health, so you can't call the PERT. Okay, we got to vote for 10. Any other votes? You can always call pharmacy, so it's kind of a get out of jail free card. But the ultimate dose is 100 milligrams over 2 hours. And so Cassandra was part right. So your first dose is 10 milligrams, and then you do a 90 milligram dose, and combined that gets you 100 milligrams total. So let's pretend this gentleman's not in shock. He's coding. How fast do you give the TPA? Yeah, so if they're coding, you give it basically all as a push. And then just as a teaching point, if you give TPA during a code, you have to wait about 15 or 20 minutes to give it time to work. And so you can't give the TPA and then call the code immediately, or else you've wasted TPA, essentially. You need to give the patient time to have it circulate and have the clot break up.
Let's say people do like 100 at one time, or do like 50 and then 20 minutes 50. Is there like any evidence to say like which way is better? Or...
Good question. I am not aware of any evidence. I think all of our protocols at all of our hospitals, it's 10 and 90. I think if you go...
No, for like for coding.
Oh, if you're coding, no, I don't know evidence to suggest that that's any different. Interestingly, we treat massive PE with TPA based on like a very small case series that showed that it prevented people from dying, but I think there's only like 5 or 6 people in the case series. And so of things we do in medicine, it makes physiologic sense, but there is very little data to support this. So, all right, so massive... Yeah, exactly. It's a good dose to remember. And then the other teaching point here is if you're for interns next year when you guys are running codes, if you're going to push TPA, you need to ask for it as soon as you consider it, because it takes them a little bit of time. Usually they have to run to the pharmacy, you have to reconstitute it, and then you have to give it. And so if your story is convincing enough when you walk in the room, I would ask to mix it. So you're either wasting TPA, or worst best case scenario, you're giving it sooner rather than later. Okay, so this person gets TPA. What else do you have to give this person at the same time? Fluids. Okay, great. So you're giving fluids. He's already on vasopressors. Taking that out of play. Great. So this gentleman needs heparin or some form of anticoagulation before and after the TPA. You stop it while the TPA is being given, but he needs this before and after. Yeah, great. So Cassandra asked, can you just give him a shot of Lovenox? So yeah, so Lovenox or low molecular weight heparin is recommended by, I think, even CHEST and some of the ATS societies now. The reason we, historically didn't do it is if you need an intervention afterwards, you're more likely to bleed if you're getting Lovenox because you're giving it as a bolus, you can't reverse it. That being said, IR at the U, at least as far as I know, has told people they don't care. And so if you are concerned enough the person has a massive PE, I would give them this low molecular weight heparin, get them therapeutic quickly, and be sure that you're actually treating it. And then IR and all other services will be comfortable with the bleeding risk. And for those people that are concerned that if they needed some sort of cardiac surgery and they're going to bleed, cardiac surgery gives everyone heparin before the surgery starts anyway. So everyone else cares less about bleeding than we do. Bleeding is fixable. Obstructive shock with a huge clot, not super fixable. Cool. So that's massive PE. The very last thing, which I forgot to show for that first case, which I'm going to show because it's a great X-ray, is this. So this was this gentleman's X-ray for that first case, the gentleman who came in with Tamponade. Right is now, left was a month prior. So we'll say for this one, we'll do another intern. You already know the diagnosis. So what is the finding on here?
The heart border is really enlarged compared to prior. And probably have that pleural effusion here.
Nice. So Elizabeth said the heart border is really enlarged compared to prior, which is exactly correct. And then she called out that pleural effusion on the right. And so this meets true criteria for cardiomegaly. So, greater than half the diameter of the thorax. And, in the old days, they referred to like the water bottle heart. And so like when they say water bottle, it's like the old school canteen. It's like not your Nalgene or your like Contigo bottle, but that's technically right, your old school canteen shape. I don't know. That's probably one of the terms that has gotten lost in the modernization of medicine. Sorry, Dan, say that again. I had you muted.
No, nothing. It's like a Bota bag. It's like it's like before plastic was invented.
Great. So we have a Bota bag reference from Dr. Heck. So, yeah, no, that's exactly it. It's like not a water bottle that we would ever think of. So I think when I was like an early med student, I was super confused. It's like water bottle heart. I presumed it was like something super narrow. It turned out I just dated myself.
But I think the other important feature is that you lose you lose all the shapes of the heart, right? You lose the left atrium and the aortic knob and all that on both sides. It becomes smooth.
Yeah, great teaching point. So Dan said right here, so knob, that's your first mogul, and that's your next mogul. And so if you imagine a skier going down, right, you get your aorta up here, your pulmonary artery right here, and then your LV right there. And so, right, he's correct on this one here. You just get this kind of flat contour. And so you lose the moguls, which is another sign of a pericardial filling process. Great teaching point. Any questions about anything we have gone over today? So just as a reminder, we started out with 3 fairly inexplicable pictures, but you guys worked through them all. We talked about a gentleman who had abdominal compartment syndrome. So what's our differential between high peaks and high plats versus just a high peak? Talked about how we treat abdominal compartment syndrome. We then talked about pericardial effusion and cardiac tamponade, our A-line tracing, why pulsus happens, looked at a good X-ray. And then finally, somewhere, we did a callback to what the RAC residents are doing in their ultrasound stuff right now. We saw that there's a clot there. And then we talked really briefly about what a massive PE is and how we treat it. That's it. That's all I got. Thanks, guys. As always, have a great day and let us know if we can help with anything.